thank you very much. Natalie, I appreciate connecting again. It was great to be with you all in person recently when you were nice enough to come all the way down to SoCal for the meeting a few months ago. And I'm very impressed with what CPCA is doing and excited to be involved, but I'm busy in the trenches. In fact, that's why Natalie asked me to talk about this specifically, because I'm involved actively in the teaching health program and I'm an active faculty member in training right now. Let's just quickly, I've been a family medicine faculty member for now rounding in 25 years. I've been in 4 community health centers over 4 decades. I've been faculty in 4 programs. I've been program director in 3 of those. And my focus over the years has been education in underserved settings. That's really what my life has been. And I wrote the Teaching Health Center grant for SAC Health System in close collaboration with Loma Linda, and oversee those 3 specialties. And I'm a preceptor in the family medicine residency, and specifically also at SAC Health System, I oversee quality and population health. That's my administrative role there. So I'm a QI guy. So, all right, so let's dive in. Overview. I'm going to talk about traditional residency training and evaluation that I was a part of years ago. Then move into the ACGME Outcomes Project and how that has been changing how we've been looking at things and doing things. Talking about specifically looking at clinical knowledge, skills, and attitudes, KSAs, quality performance measures across in different federally qualified health centers. Then talk about quality improvements specifically, the training around that, and then talk about incentivizing improvement. New technology thing. We're going to try this. I understand from listening in a little earlier that there are a bunch of you that haven't begun yet, but a program trying to get this poll everywhere to work, and it is not kicking in. All right. One more technology issue. So I've embedded it, and for some reason it's not kicking in. Maybe, is there any way that I could just get a sense, Natalie or someone there, of the breadth, the answer to this question? How many people have either not started yet? First ask that question. What percentage of the room have not yet started a training program?
Wait a minute. Sabrina, you can't say you haven't started a training program. You've got credit.
Don't have residents yet.
We don't have residents yet. Okay, you don't have residents.
So about 6, 7 folks in this room.
Do not. And then the remainder, and then how many do have residents?
6.
Okay, so it's pretty
Let's say it's about half and half.
Okay, very good. All right, so things have been changing. So we're not doing leeches anymore. And the way that we interact with patients is a little more balanced. Doc's saying, I didn't ask you to undress so I could examine you. It's essential to our relationship that I be fully clothed and you not be. So a lot of things have been changing, and it's for the better. So traditionally, historically, assessment has been pretty much, can you hang in there and not offend anybody too much over a few years of training, then we'll graduate you. And unless you're really incompetent. There is an unclear assessment of the progression of expertise of the trainee over time, and there's a lot of variability from program to program. The assessments, therefore, weren't really emphasized, the details of those assessments, and we were really reluctant to fail anybody if they joined us. And the whole idea of repeating an entire year, not only was it expensive, but it just wasn't something that I ever saw done. You let them go, or not really work on specific competencies back in the old years. So, assessments seem to be sort of a waste of time. Here's another question that maybe you can help me with, since this isn't the poll everywhere isn't kicking in. What percentage of people were already involved in healthcare in 2001?
Let's say about 25%, 30%
Okay.
of the room.
All right, so I'm old. I get it. All right. So back in 2001, Crossing the Quality Chasm was produced, and just before that, Ur is Human by the Institute of Medicine. Both emphasized that we were having an issue with the variability of physician competence. So the ACGME picked up on this, and they instituted Milestones 1, and now we're into Milestones 2. I'll talk more about that. Now, the idea of working on milestones is based on the Dreyfus model of skill acquisition, where you begin as a novice, and this is, a late medical student or, intern, early intern, where you really have to be closely supervised. Advanced beginner is someone who can do straightforward things. Competent is just, over threshold competent. Still need work, but basically competent and likely not to hurt people. Proficient, fully acceptable, ready for prime time. And then expert, a percentage of people go on to be experts. So David Leach picked up on this. He ran the ACGME until 2007. And under him, the core competencies for physicians were developed. When I was at Dartmouth, this came down. We started to include it in the way that we evaluated our residents. Patient care, and this varies out by specialty. Medical knowledge, again, varies out by specialty. And then professionalism, systems-based practice, practice-based learning improvement, and communication skills. When he moved on, and Tom Naska, a anesthesiologist, stepped in, we moved on to the next accreditation system. You might notice that the first three letters of his name are the same as the letters of the next accreditation system. Anyway, he published this article in the New England Journal back in 2012 saying that the reason why things had to be changed is this variability of quality of residence and this increased formalization of subspecialty practice. So many more subspecialties with more details about how their training should be different than another. So this next accreditation system emphasizes outcomes over process, not just finishing X number of years of residency, but being competent at the end. Annual surveys were first included. This wasn't the case when I was first in GME. Residents and faculty both receive anonymous surveys that go back to the ACGME. Annual program web-based update, web ads as it's called. Instead of just having the every 3 to 5 year site visits, now the site visits are done as needed. And once you have accomplished full continuing accreditation, full-fledged accreditation. Milestone reporting is a regular thing. It's submitted every 6 months. Each discipline determines their reporting milestones, every specialty. And then the CCC, the Clinical Competency Committee, they expect a full hour per year per resident, split over several meetings, but total of about an hour is what they hope for. And then there are clear visits of the institutions that are hosting the GME programs. So let's talk about Milestones 1. It had been running for several years, and Stan Hamstra, PhD at ACGME, went on a listening tour, went from place to place to place, and asked about how things are going with this approach. And people said it's complicated, the milestone wording is kind of tricky and vague, and hey, we're busy. Our views always win. You got to make these assessment tools more practical. I said, okay, but are they working, he asked. And this is one of his slides, and he was happy to show everyone at the last conference where I heard him, that if you look, can you see my cursor? I hope you can. PC08, primary care 08 is traumatic brain injury. In neurosurgical training, you will see PC08 here, the dark line going up. It was almost 100% of folks by the time they finished training were found to be fully competent in that. Whereas pain and peripheral nerves, you see down here, PC04, was always lagged behind. And there was not there's a substantially lower level of percentage of folks that reach full competency by the end of year 7. And that was pretty consistent across the country. And he just was so happy about that there was some consistency seen, some validity seen in Milestones 1. But the validity is not nailed down yet. Still have a lot of work to do. He says the issues are that experts, we all think we're experts, we are to some degree, but that are involved in GME, we're the ones that get together and decide on these things. And the question is, are we really responding to data instead of our own opinions? The response process, is there a shared mental model across programs? Okay, so if you have a residency program that's at an academic medical center in a posh part of a city versus one in a rural setting, do we have the same view of what a resident should be like? There's obviously some issues with that. Predictive validity, can a blinded set of assessments predict the PGY level? Can you have a resident in front of you and you're a visitor and you have no clue what year that resident is, and work with the resident and then do an assessment and be able to peg that year of the training for that resident? Are they that good? Then consequences, how does this rating system affect our behavior? Are we, do you aim for the test, so to speak? So competency is like a biopsy. It's just, looking at different angles, taking little biopsies here and there. It's not perfect. But that's why the design is to get everyone together to talk, to try to get different perspectives. And making the right decision is about avoiding false positives. Hampshire, when he gives this talk, says that we euphemistically call pre-competent residents, those that aren't there yet. And the question is, will they in fact be there by graduation, or are they going to be the false positives here? Or can we accurately say, they're not going to be competent? And at what point will we know that they're not competent? So here is one subcompetency for emergency medicine, wound management, where we see that folks in the upper curve end up being level 4 or fully competent by the way that things are designed by the end of their training, whereas the folks that never really quite get there, they're stuck at level 3 at the end of their training. When do we start seeing the curves separate? It'd be great if we saw it way back here, where, at the beginning of training, that first year. But it seems that things separate out by the end of the second year. Then we only have like 12 months left to work on it. The hope is that we could identify training gaps for residents earlier to be able to address them. So we're not quite ready for prime time, is what Hamster would say. Still need correlation back to medical school, tighter, better milestones presently, and that's what 2.0 is about, and correlation forward to predict what practice performance is going to be like. I really appreciate Dr. Chen's comments about board exam scores versus training program and predicting efficiency and quality of practice going forward. That's the kind of thing that ACGME is trying to focus on at the program level. And it is not a surprise to me, having been in a variety of training programs over the years. There is variation from program to program, different areas of strength. And it does matter where you train. It's not just if you're in the United States in a ACGME approved program. There's variation from one to the next, and the hope is to reduce that variation. So you see at the bottom there, it is still the program director's call. It's very clear for the ACGME. All these assessments, all these forms are to help a program director, but program director makes the call. So what about these forms? When you create forms that are informed by a milestones-based approach, you got to be careful that your evaluation forms, at the end of a rotation, you give an evaluation form to the faculty member that's been primarily responsible for that rotation for the resident. It can have 20, 25, all of the subcompetencies on the list. It's just too much. So it's best to pare it down to about half the subcompetencies, something like that, for each rotation, and make sure you cover all of them. But for each form, it can't have too many. You can't have too much language. It's just too hard to read and use the form, so you got to make it tight. And they can have ambiguous language. So what they emphasize at ACGME more and more is that there have to be behavioral anchors as much as possible, language that refers to specific clinical behaviors that everyone would understand. Okay, so when it comes to evaluation forms in the Milestones 2.0 era, again, there are too many subcompetencies for one faculty member, so you need to map this. So what we do is we'll sit down, we'll take all the subcompetencies, we'll go rotation by rotation and see which of those rotations see certain subcompetencies best, and pick out a dozen or so for that rotation. Go to another rotation, like say a research rotation that's not as clinical. You can get some other things that you focus on, and in the end, you cover all the subcompetencies, hopefully a couple times a year. 360-degree assessment is emphasized and important. It's not just faculty. We don't want to just use the assessment of what the faculty see face-to-face with the residents. We also want to see what happens when the faculty member's not around. Nursing sees that. If you're doing quality QI projects regularly as a part of your training with your residents, the QI staff see that, and they can be asked certain questions that also line up with those subcompetencies. Obviously not as many as a faculty member can, but some. ACGME, by the way, does not want you to take the Milestones language directly from their language that they give you and put them on the forms. The purpose of that language is to give you a gestalt when you're together talking with the resident about how a resident is doing. In Ottawa, surgeons did a great job of this behavioral grounding of evaluations. They together were able to agree independently. Each of the faculty were given a list of the residents and asked to rank them according to these 5 questions, and it was amazingly consistent. Each separately coming to the same conclusion. Number 1 on the scale. Did I have to do the procedure? Was that resident so uncomfortable with that procedure that I basically had to do it and they were watching? 2, they were okay to, kind of stumble through it, but I had to talk them through step by step. 3, I had to prompt them from time to time, but they were doing pretty well. 4, I needed to be in the room just in case because they were pretty good. And then 5, hey, they really know how to do that procedure as well as anybody. I didn't really need to be there. That kind of behavioral grounding is what we're looking for. All right, so the process for creating Milestones 2.0 by the ACGME, they created 2 working groups. The first was the harmonized milestones. Now, system-based practice, practice-based learning and improvement, professionalism, and communication, those 4 core competencies, they found with their studies to be not all that different, specialty to specialty. So they said, you know what? Let's come up with a harmonized set that we can just use for all specialties. But then when it comes to specific patient care things and medical knowledge, clearly that's different from specialty to specialty. So they had a different working group that looked at that. They included a public member in each group and residents from the different specialties. So they did a lot of work. They came up, this is give you a sense of things. Neurosurge has these many patient care subcompetencies, orthopedics, that many. Come down to internal medicine, there are 5. Medical knowledge is 2, medical knowledge is 16, very specific. They split it up all crazy for orthopedists. Transitional year, the 1-year internship. That's kind of pluripotent. The trainees can go on to categorical programs after that 1 year. Was 23 total subcompetencies with the non-harmonized 4 core competencies. But as of July, transitional year and a couple other specialties will now be trialing, will be the first canaries in the coal mine for the harmonized milestones. So 2.0 is started last month. And there are now 3 system-based practice, 2 practice-based learning and improvement, 3 professionalism, and 3 communication sub-competencies. And again, patient care and medical knowledge vary by specialty. So if you look at TY, transitional year, here's all the proviso language that's going to be there for everybody, all the specialties about milestones. Milestones neither represent the entirety of the dimensions of the 6 domains of competency, nor are they designed to be relevant in any other context. A graduation goal is what level 4 is, but it does not represent a requirement. And again, decisions of program directors. So furthermore, Milestones 2.0 include revisions and changes that preclude using them as a sole assessment high-stakes decisions like, do they graduate to the next year? Do they in fact graduate at all? Those kinds of decisions. They're just to help you. Here's an example of interpersonal communication skills. The second subcompetency in the harmonized set, so all specialties will have this. And I suggest to you when you're talking about the 360 degree reviews of residents that this is not a bad one to have nursing staff assess. Checking that the resident checks their understanding of recommendations, use active listening with the team. They provide feedback to peers and learners who are talking. These kind of communication skills are well observed by nursing. So this is one of those that you could give to nursing to assess. This is one I hope you can help me with, this question. If you're a member of a CCC, I guess there are only a few probably in the room, do you include members of the Clinical Competency Committee that are not a part of your core residency program, not faculty, not administrators for the residency program? So how many people do we have that are on CCCs?
One.
Oh, all right. I'll just move on. So clinical counseling committee is very important. Okay, I think it's a great innovation. This was kind of happening before, but now it's been formalized, handed down from ACG as a requirement for all programs. And its purpose to have at the least semi-annual, most programs that I've been a part of, it's quarterly, but there's a reporting of the conclusions of the faculty and staff regarding the competency of residents semi-annually to the ACG. So the purpose of the CCC is to advise the program director, who once again is the person that has to make the decision. The CCC is just an advisory committee. Membership is the chair, which is a faculty member who is not the PD, 3 program faculty as well, in addition. A societal representative is suggested but not required, and the non-voting members are the program director and the program coordinator. Okay, so you have all these people in the room. In many residencies, all the core faculty are on the CCC, and societal representatives specifically for us. I'm the CCC chair for preventive medicine at our institution at Loma Linda, and the CCC chair for our program is from internal medicine. So there's a mixing and matching of the chair. So that person has a little bit of objectivity. And then the societal representative, we bring program coordinators from different specialties to come in and then be the societal representative, a non-physician. And I'll tell you, a couple years ago, we had to terminate a resident he needed to be terminated. And it was, all the docs were hemming and hawing around the room. The societal representative said, I don't want to be treated by this resident. We gotta do what's right here. And it really helped us to get over the hump and make a decision that was hard. All right, bolstering resident clinical knowledge, skills, and attitudes. So didactics, traditionally, they're just, most residencies have had a series of 1-hour lectures, repeating a bunch of core topics every 18 months if you're a 3-year program, every 2 years if you're a 4-year program. So most residents will receive at least each topic at least once. Recent trends are to go towards shorter didactics, 45 minutes or less, involve senior residents more in presenting, involving more adult learning techniques. Andragogy for Knowles is having problem-focused presentations, having clear immediate application in your day-to-day practice. Have the opportunity for people during the didactic to answer a question and be right or wrong, having mistakes possible, make a decision answering questions, and then help to evaluate the training at the end and give feedback. Those are very effective, and involving those principles in regular didactics is important. And then we're relying more and more on online materials. Precepting. Most precepting sessions should be core faculty, and this is because of the CCC, right? Or if you have an adjunct faculty member that's willing to be a part of the CCC, that's based at one site where the residents are a lot, that might make sense to have that person have several precepting sessions. The point is, you want to have people in that CCC meeting who are in contact with the residents a lot. Face-to-face faculty contact with patients is required. This is rules, ACGME, and an agreement of CMS. During the first 6 months of the intern year, by 1 year, has to be the faculty member cannot just depend on the intern. You have to go in and see the patient yourself. CMS has a primary care exception which is used in the United States, in the nation of California. That has not been applied. Everywhere else I've been, we, as of the middle of the intern year or a little later with residents that aren't doing as well, we'll be able to start going in with some patients and seeing some patients and not having physical presence with some others, with residents that are doing well. But in the state, if you are not in the University of California program and you're taking care of Medi-Cal patients, the attending physician has to be present with the patient in order to bill. So that's a reality, which I think is unfortunate. Our institutions would really love that to be different. When you're a second or third year resident and your boss has to always come in, it mitigates against the resident-patient relationship, and also it reduces the independence of that, the growing independence of that trainee. I think it's unfortunate that that's the case in this state, but at the moment it is. OSCEs are important because they're fair. An objective, structured clinical examination, having that mixed in once a year, twice a year, just having these set up is I think, an important part of training. What you do is you train an actor to take the role of a patient, and they memorize a case presentation for a patient and certain condition that makes sense for your specialty, and then the resident has to go in and interview and examine if it's something that requires examination, or if it's just interview-based, like motivational interviewing focus, then necessarily would do an examination. But then there's a rubric that you follow with very specific things that every faculty member is looking for. And then as soon as you're finished, the resident will, the attending physician will come in and join that standardized patient with the resident and give immediate feedback, which is wonderful. It's a great back and forth about that. And then again, that grading it follows a rubric and is very fair from resident to resident. Really helps you get a sense of where residents are. That's important to improve their performance. When it comes to quality measures, in a federally qualified health center, there's the Uniform Data System. If you're not in a federally qualified health center, you may be in blissful unawareness of this. But if you're an FQHC, you're quite aware that they are always collecting data regarding these things that are listed. Some of the demographics, age, sex, different characteristics, staffing utilization, certain diagnoses, how many patients do you have in each of those. Then there's the almighty table 6B. That is the quality of care measures. There are 6 at the moment, 6 preventive, 2 perinatal, and 8 chronic disease measures. Ones you would guess what they are. And every year you need to gather that data, send it to HRSA in order to continue to receive your funding. So we're always wanting to make sure that we're doing all right, obviously according to these UDS measures. If you're not in a federally qualified health center, you're still going to have payers that you're involved with, Medi-Cal, intermediary, insurance, and ours in the San Bernardino area, that's the dominant one, is the Inland Empire Health Plan. and it's a good insurance company. They have their own pay-for-performance measures. So nowadays, you can't escape measures no matter how you're playing the game. 18 measures at the moment are what we're answering to, and their incentives are given according to 3 tiers. Get all the way up to tier 3, get a bigger chunk. They're doing their best to align the language and specificity of their measures the last couple of years more and more with HEDIS measures. So it's getting more consistency across the country and across Medicare and Medicaid regarding what measures are that are being followed. Resident-specific measures when it comes to the feedback. We've been on Epic now for 3 years, and it took until just a few months ago till we were able to extract this data. It's easier for us to extract data with NextGen in the old days, but it is made. We are extracting it now, and I'm very happy about that. So here's a list of our family medicine residents, and you see the percentage of compliance with using what they call the smart data element, clicking on a certain UDS measure thing that says that you've looked at the BMI of the patient and you have given recommendations that are appropriate for it, and as a part of your care that day. You'll see that at the top you have folks that are under 50% compliance, and you have a few superstars at the bottom that never miss. They always click on that thing every time they see a patient. So this is something that we can use also to give feedback to our residents when they meet with their advisors. For us, it's a semi-annual thing where they get this kind of feedback, so they'll have the chance to improve, see how they do 6 months later. So that kind of feedback has been shown to be effective. All right, now specifically, let's talk about quality improvement. We were already talking about the quadruple aim earlier. Well-being of physicians is taking a hit because of the increasing complexity of medicine just during my career, and something we definitely need to address. What do we do for teaching quality improvement? I see quality improvement as one way to address this issue of well-being. If residents learn during their training that they can have an impact on the way the day-to-day life, routines are. If they can make things simpler and more efficient for their own workflow day-to-day, that helps. So that's a big part of our training. We have face-to-face didactics, which I happen to be responsible for, just to get the ball rolling with residents. We have them go online to the Institute for Healthcare Improvement, IHI, to their basic certificate. If you're not aware of these, got to use them. They're great. For the faculty, we have them do 24 hours worth. For the residents, because there's some teaching and other things available for faculty development. But for the residents, we have just the QI modules, which is less than 10 hours. And some of them a lot less, depending on how quick that resident is. So we have, again, these are the didactics. And then there's the more practical side of teaching. All residents interact with behavioral health. We have co-located behavioral health at our clinic, and population management tools. And we do a variety of different kinds of visits. And every resident is involved in actually 4 QI projects. When they're an intern, they just do a little bit of literature review. As their second year, they do a little bit more. Once in their third year, final year, they'll be the co-leader, and then they'll be the leader in the end of a QI project, and have the primary responsibility for it. Work with their clinical team, nursing and others, and the QI department helps. And then they report it out at quarterly meetings. So Osler said, medical care must be provided with utmost efficiency to do less disservice to those who treat and injustice to those we might have treated. And those of us who are in community health centers totally agree with this. So one thing that we have done at SAC is to decrease our cycle time with a series of QI efforts, and so I'll just walk you through this. Number one was we eliminated, you see there, blood draw. This is something that was done by the MAs. We did, it's just the way things used to be before in the old days, and we just realized, you know what, why don't we pull the LabCorp, the company, come in, let them rent a space right in the clinic, and let the resident, the patient, leave the room and go over there, open up the room for somebody else, right? So we eliminated that step. Next was 2 was communication, physical flags. So we had NextGen, and NextGen was so cool because you could track really closely at what stage the visit was. And we thought that would take care of things, but things slowed down actually when we brought in NextGen. And we realized that to use that tracking method, you had to be back at your workstation, and people are running around doing things. So we went back to the old-fashioned physical flags by the door, by the exam room doors, and that helped. Number 3, things were tight, okay, regarding money. I'm sure no one has that issue besides us, but so therefore the ratio of MAs to residents was low enough to slow down the productivity. And we made that case to the administration, and they agreed, and we improved that ratio, and that helped decrease the cycle time. Number 4 was we fine-tuned the precepting, okay? We allowed the senior residents, 2nd and 3rd years, to walk in and say, Dr. Shannon, I'm busy. Can you give me the short version? And I'll say, oh, okay, fine. What do you got? And we'll go quickly with a senior resident. Interns, yeah, they couldn't say that. I'd have to, be methodical and take more time with interns regardless. But the seniors could say, you know what, I got time. Let's talk about this, or not, and that helped. 5, task reassignment. MAs usually actually do the discharging of patients, so making the appointment you see up there. And we took that step away, created a discharge desk, again, to open up a room so the next patient can come in. And then finally, there's another one, training. We started having MAs pen preventive orders, the typical orders that measures are centered on, so that the residents just had to click on them, and that helped. And then finally, we almost began this, the e-pen. I don't know if anyone still is using NextGen and was able to get into the e-pen, but we're in the process of developing the process where we can have the patients in the waiting room answer some questionnaire, and it would be imported directly to the EMR, so that once the patient was in the room, the resident was there, they'd have history ready for them. We ended up going to Epic just at the time we were going to adopt that. So we didn't quite do that. That's 7th step, but we would have. So over 2 years, we went from 107 minutes average cycle time to 77 minutes with this. And by the way, during this time, we began the integration of behavioral health, co-location, sitting right there in the pod with the residents. And despite that, which ended up slowing things down slightly, we still were able to have a substantial reduction in time. So this is what QI does. This is what gives residents hope that they can make a difference in their day-to-day lives. When it comes to feedback, we have a presentation at the end of that final QI project that each senior resident has. They present before faculty, staff, and residents, and they are given a very detailed feedback on each aspect of what they reported. Their presentations are to include the problem, the objective, stakeholders they engaged, root cause analysis, literature review, change they implemented, measures that they were following, their data analysis, evaluation of everything, and drawing conclusions, and then whether or not that innovation would be sustainable. Here are a couple of charts the residents created. This is chronic opioid therapy that they're trying to improve referrals for adjunctive non-opiate approaches to pain. Here's one to increase cervical cancer screening rates. And here is, hard to see, but here is the rubric that we use to evaluate these residents when they're doing the presentations, the QI projects. You see in red These are behavioral, very specific behavioral requirements for a level 5. So you can't get a 5 unless you've done all of these things within the parentheses that are explaining it, or each of these 10 categories. So it helps to improve the inter-rater reliability of the faculty that are evaluating and give a little more specific feedback to the residents. All right, incentives. Let's just move on. Incentives is the question. So this guy says, hey, my boss is giving me $150 and anyone stops smoking by the end of the year. If I start smoking now, I'll have time to join the contest. So incentives sometimes don't do exactly what you want them to do. You got to be careful with how you use them. Let's just give you a couple ideas here about what has been shown to change behavior. First, at the top here you see information. Information alone usually is not adequate. Giving information. The whole area of motivational interviewing certainly brings to the fore that information alone is not adequate. Let's talk about a few things that work though. Status quo bias. Okay, this is leans on the reality that we all don't want to be under normal. We don't want to be subnormal. We want to be at least normal. And one classic example of this is in the UK. They're trying to decrease the percentage of people that submitted their tax payments late each year. And they started with a bunch of negative reinforcement kind of approaches. And then some psychologists got involved and decided, you know what, let's use a status quo bias. So they put a statement at the bottom of the letter to those that are late that just said 9 of 10 Britons submit their taxes on time. And that immediately had a significant bump. People want to be seen. They want to be in the pack with the normal. Choice overload. If you give too many choices, people just throw up their hands. So you got to be careful with that. And these modern EMRs, I'll tell you, so many choices. It's very important to pare those down and have kind of standard things or defaults that you go to. Immediate incentives are stronger than having to wait forever. It's the reality. Loss aversion. If you're given something and told, here you go, you get this as long as you do these things, but if you don't do these things, you're going to take it back. Actually give something first as opposed to a bonus at the end. It's been shown to be more effective. Relative social ranking. Again, docs don't want to be the low performer. This is kind of a variation of status quo bias, but more specific. When we give that resident feedback, remember that bar chart with performance for adult BMI? We give them, we put an arrow to where they are. So they see where they line up. They don't give the names for all the other residents, but we show them where they are. And they see that wow, some people were 100% and I was 60%. Granted, I wasn't the worst, but boy, I want to be better than that. I want to be the bottom part of the curve. So that's important. Goal gradients and progress monitoring. The incentive to change is stronger if you are close enough to actually achieve a threshold, and if you work together on teams, this also helps. An example would be this year specifically, or this past year, the 2018 measurement year, for the incentives for IHP for us, for P4P, there was a threshold number for the combo 10 set of immunizations for children that included, combo 10 included influenza and the diarrhea vaccine. I'm blanking on rotavirus. And those two are notoriously difficult if patients come to you being behind. You can't catch up on rotavirus, and it's difficult to get 2 shots in for influenza. Well, their threshold is just too high, even for tier 1. not to mention tier 2 and tier 3. And we were hearing from other folks in the region that they just, it's like almost impossible to reach tier 1, much less any of the rest. You just throw up your hands and say, well, let's focus on something else. Next is limiting willpower and individual effort. It's better to set up defaults than to rely on memory. Boy, I did research on this years ago before computers, back in the dark ages. And it was clearly the case if residents were presented with a short list or given BPAs, the best practice advisories, given some kind of reminders in huddle sheets, some way of focusing them on the things that this patient needs now, instead of having to go back and stop in a busy day and say, okay, what are all the list of possible things that this patient might need? It just doesn't work to depend on memory. So figuring a way to make things default and easier makes a big difference for behavior change. And then finally, mental accounting and salience. It's been found that giving a bonus check as a separate check that's mailed to the house of a physician is more effective than having it just automatically deposited electronically. Having that check come to the house and the spouse sees, oh, look at that, you got extra money. How'd you get this extra money? And that makes a difference. It's a more salient experience. People remember it, and they're more likely to be incentivized to repeat that behavior. So which of these applies to residency training best? Social ranking and progress monitoring without money. Comparing one's own average performance against others in a group or / national average for attending physicians. This has been shown to be important. And again, having quarterly reports or at least semi-annual reports shared with the resident by advisor with their specific performance makes a difference. Making rewards salient through timing and teams. So one thing that we like to do is we have QI projects that are we have 4 sub-teams in our residency, residents and staff and nursing and everything, and divide up into these teams. So we have quality awards that are given for best projects, and teams get a party of some kind, that kind of thing. So it's a fun thing for the team to do together to get that. When it comes to that physical check for a monetary incentive, that idea, Advocate Healthcare in Illinois does it in April, just before taxes. Mass General does it in Massachusetts in early December, just before you need it for the holidays. And when I was at Dartmouth, the incentives were given to us by practice teams attending in nurse level. So again, this idea of timing and teams. And then finally, this idea of limiting willpower and memory being required. So a methodical set of PDSAs to alter your common processes to come up with these defaults that everyone knows make sense for your practice, for your team, for your clinical realities where you are. And then have each resident lead such a QI effort, working together with nursing and others to innovate and do things that make sense to them. You see them light up and really lean into those kinds of efforts. So again, giving them hope for the future. All right, one final comment. So if you're doing that, what do you expect your child to do, right? Same with training. So Ben Franklin said a lot of good things. Well done is better than well said. It's certainly one of them. And I would just say that when it comes to bumping behaviors of residents, improving their performance, one of the most important things is what is required in family medicine, which is you need to have at least one faculty member, better more, practicing in the same practice. So the residents see them doing these things, modeling the performance that we're asking them to provide. And that's key. All right, those are my prepared comments. Any questions?
We've got a question for you, Kevin.
Actually, it dovetails off of that last slide. Do you have any requirements for your preceptors / faculty teachers? Do you evaluate the teacher's performance, and what kind of training do you provide for them, given it is a skill set to know how to evaluate people, give feedback, etc.? So
Yes.
All right.
Yes. Yes, the faculty are regularly evaluated by the residents and there's also feedback from nursing, and they are given feedback by the program director on an annual basis, at the very minimum, or more frequently if needed. But that data from the anonymous surveys is fed back regularly to them. There's also faculty development around the issue of precepting and also just teaching methods in general. But yeah, so there's faculty development around that specifically.
Any other questions? Oh, we've got more.
Really simple one. I have a really simple one.
Okay.
Is the QI project, does that fulfill their scholarly activity requirement for residents?
Go ahead.
It does. It does. In family medicine, scholarly activity is satisfied by a quality improvement project. Yes, so that's what we have gone to in the last few years. Yeah.
There's another question.
Just to clarify, when you said that the preceptor needs to see all patients, I understand for the first 6 months, but what were you saying about second and third years? Could you clarify that?
All right. So again, we're in California here. So every other state where I've been, I'll tell you the rule for the other states. And that is that for 6 months, every patient that is seen by the intern, you have to go in and say hi to that patient and summarize, ask questions, and make sure you have seen and touched that patient, to repeat the exam if you need to, etc. As of successful completion of the first 6 months of training and an agreement among the preceptors that intern's doing okay, then from that point on, for the remaining 2.5 years of family medicine, 3 years of training, same with intern with peds and internal medicine, the choice is up to the faculty member on any given presentation by a resident whether or not they need to go in and see the patient. It's no longer required if it's a simple visit. If it's a more complex visit, then they have to go in anyway to build the higher billing codes. But that primary care exception to physical presence requirement has not been allowed here in the state of California. I call it the nation of California. And that is purportedly for safety of patients. Why they give an exception to University of California programs, I don't understand. But the requirement is every single patient, regardless of complexity or lack of thereof, the attending physician has got to go in and see the patient. So that's what we do. And in fact, we had a state audit earlier this year that honed right in on that, on the evidence that we had physically seen each of those. And we're really conservative, and we follow the rules, for better or worse. And so we passed, fine. But apparently, people who aren't documenting well, the attendees who aren't documenting well that they're actually going and physically seeing the patients, there have been financial consequences. So some of those audits.
So, Kevin, this is Kiki. Natalie and I are both chomping at the bit to jump in on this one. This is such a multifactorial issue. There are many layers here. What Kevin said is correct. And as federally qualified health centers, realize that residents are not allowable providers. Okay? So, every resident visit, every resident encounter, until they are licensed, must be precepted. Otherwise, you might as well just have me go see the patient. Okay? That is not only a state of California rule, that is a HRSA, Medicare. It's a Medicare rule, the allowable provider issue. Okay? Add to that, in California, those that are teaching health centers per the 2019 SPA or 2018? 2019 SPA. 18 state plan amendment. Those that are teaching health centers, that they are exempt of that allowable provider component. Okay? But then you add the layer that in California, effective January of this upcoming year, 2020, we now have postgraduate training letters, licenses. I always get the L wrong.
Details.
Details.
To be
To be determined.
Yes.
Okay,
So it is
because
July or August. Yeah.
yeah, exactly. Here it is, August. Residents. And come January, a resident won't be licensed until they graduate. So what does that do to the supervision issue? And trust me when I say CP and the allowable provider issue, and trust me when I say CPCA is all over this issue, trying to get a definitive answer. Because the answers we've been given to date, and Natalie, slap my hand if I say something I shouldn't, the answers we've been given to date of it shouldn't change a thing doesn't make sense. Okay, so CPCA is running, taking the lead on figuring out what's the what so on this, because January's right around the corner.
Yeah.
Yes, Marianne, you want to add on that one?
I'm just saying it is actually quite confusing.
Yeah.
Yes, we don't know yet exactly what's going to happen. Supposedly in October is what I've heard. We know what to do with our current residents. And one of the goals was to get all of our second-year residents licensed as quickly as possible, so that the group that are second years now will be licensed.
Who is that?
Before January 1st. So that's what we're focused on right now.
You'll run into some program directors. Kevin mentioned this. Ivan Gomez, the former program director who we meet tomorrow from UCSF Fresno, he'll say the same thing. We just precept every visit. That way we know there's not going to be any issues. But it does start to get a little frustrating when you've got a third-year resident who shows a level of competency. Why would you want to precept them? So that's where the to be determined really starts to come into play. But never forget the allowable provider issue. In this room, it's important.
Just a good section between the precepting and the billing, the Medi-Cal, that was.
It is, okay, this gets into a whole, Natalie, help me.
How about we pause that discussion because as Kiki said, it's still to be determined. We are getting a lawyer to help us review some of that. We are developing a work group that will be meeting in the next couple of weeks to address some of this. So we are actively making efforts to understand this space. We've talked to the Department of Healthcare Services, Department of Healthcare, the Medical Board. No one can give us answers. So I don't want to create too much anxiety. What I do want to say, though, is we are actively working on this. We will be sharing more information as it becomes available. So just hold on tight. We will find you answers.
Did I raise the anxiety? Mike's praying now again, didn't I?
I think everyone's awake now, which is great. In case anyone was getting a little sleepy, but I will want to maybe just move this on to Mary.
Okay, well, thank you. Let me do a quick introduction of Marianne.
Yeah.
Kevin, thank you so much.
Thank you.
All right, next up to talk about scholarly activity is Dr. Marianne McKenna, who, although I've known her forever, I like to change people's titles and names and things like that. So Marianne is actually the program director of the, I'll read it, the Scripps Family Medicine Residency Program. I threw in Chula Vista in there somewhere.
No, right. Well, all of those are possible add-ons, so I'll explain our whole structure. It's a little
Great. And one of the things to know about Marianne that makes her a real rarity is she's been the program director since the day this program opened. Okay? We don't see that anymore, right? Program directors' lifespans are not all that long. So Marianne has graduated some amazing residents, including Dr. Maria Carretos from San Isidro Health. Yeah, so you look around the state and you can find Marianne residents. So welcome, Mary.
Thank you. Thank you very much. Does everyone want to just like reach out and stretch for a second? I know I'm standing between the lunch break. So anyway, yes, so I will just do a little brief introduction of myself also. Mary Ann McKenna, I'm a family physician. I have been in San Diego, first as a faculty at UCSD in their family medicine department since 1987, and then was part of the group that looked into stepping into the community for medical education, which in the mid-90s was still kind of a new idea. So I'll talk a little bit about that evolution. I think one of the things that Kiki and Natalie asked me to give a brief history as I start, because we have been doing family medicine education in a community health center setting for now 20 years. And so I think I can, I hope, give some very, shed a positive light on what some of the opportunities are in your emerging partnerships and plans. I will say, when I was offered the opportunity to give a talk on scholarly activity, I did have a little moment, because even though I've been at this for a long time and our program has, I always feel like we could be doing more. Do we, meet all the requirements? We should be writing more papers. There's more that we could do. But it was good for me to tackle this and to reflect and to realize that we all have opportunities in our settings to do important scholarly activity, and I'll help define it, I hope, in a way that doesn't create a lot of anxiety about meeting this requirement. So that's sort of my intro. So just to say a little bit of background, as I mentioned, as a faculty at UCSD, I had actually had some of my early exposure to medicine and thinking about going to medical school myself in a community health center, community clinic at that time. Your free clinic, your donation on the door, on the table, and it was, just loved that grassroots environment. So when I had the opportunity to be part of a group that was looking at providing medical training in collaboration with the community health center, I really jumped on that opportunity. And our program that is a collaboration between UCSD as our academic partner, San Ysidro Health as our community health center partner, and I'll talk a little bit about that evolution and how we, how that relationship and that partnership has deepened over the years. It's really quite beautiful. I think initially we were partners, but each with a little bit of trepidation, and now we are really immersed and linked and going on to really exciting new adventures with San Ysidro Health. And then Scripps is our official sponsor, and we're based in one of the smaller Scripps hospitals, a community hospital right there in Chula Vista, right on the border. And I'll bring some of that information into my presentation as well. We started as a 666 program. Probably a lot of you are starting there. I'll just say there's a lot of support out there, which you're going to be hearing more about, financial support for expansion, if that's something that you're interested in as time goes on. And so we're currently an 888 program. And right from the beginning, our program's goals had to do with providing quality care in the community, recruiting a diverse group of residents that reflected the makeup of our community, and hoping that our basic goal was that the graduates would stay and work in the community with a health center preferably. And I'll talk a little bit about how those outcomes have panned out. So our structure is maybe a little bit different than a traditional teaching health center, where now funding is actually coming to the health centers to be the sponsors of the program. So ours, I still call us an early teaching health center model, even though our sponsorship is still more traditionally through the hospital. Kiki and I have actually been on panels before on this topic, and I actually still think that there are some positive things about the shared responsibility for finances, actually, with the model that we have, where the burden is not all in one institution. So I think that's allowed us to, I think, to grow without a lot of financial strain. So that's good. But as you can see, we have our Scripps Mercy Hospital and Chula Vista as our sponsoring institution. We work very closely with our San Diego border AHEC. I know Ivan Gomez is going to be talking tomorrow, obviously very involved in AHEC as well. UCSD School of Medicine as our academic affiliate, and then San Ysidro Health. Initially, our main plan was to have our continuity clinic embedded with San Ysidro Health Center, but it has moved on to be a lot more than that. Now with rotations, shared inpatient work, women's health, labor and delivery, just the whole gamut where we're just linked very, very closely. I'm just going to mention a little bit about the outcomes. I mean, as I said, we started, we said, I hope we can attract students that also are drawn to this mission, to this location, and it's worked out. It's worked out really well. I think the over now 18 classes of recruitment now, we still maintain right about 50 to 65% underrepresented minority students who choose to come to our program. Given our location right on the border and our population, the majority are from the Latino community, but not 100% of our underrepresented groups. We've been very successful at helping our residents that are interested in loan repayment, National Health Service Corps scholars. And then what about where do these residents land afterwards? We still, if we track, and we do track, I mean, I think earlier one of Dr. Chen mentioned about tracking and looking at your outcomes. I have every single resident still in the spreadsheet because you will need to report that for Song Brown and for other funding opportunities. And plus just looking, to say like, wow, in a low moment, you can say, wow, this is actually working. This is worth some of the gray hairs and whatnot. But yeah, so we have right around some year 65 to 75% of our graduates still over time that are in what would be designated underserved communities. Now, San Ysidro Health themselves have at least 30 plus of our grads are somehow either in their system or have been in their system. We also work very closely with two other smaller health centers in our neighborhood, Imperial Beach Health Center and Samahan, which serves primarily the Filipino community in National City. And we have graduates in those sites as well. We have 3 community health center medical directors and 1 CEO as well. And Dr. Maria Carriel Ceniceros, who's the CMO at San Ysidro Health, is a graduate of our second class, actually. And one other thing I should just say is that I hope that this happens for you all as well, is that this idea of recruiting your local students. I know that Davis has what sounds, I just heard the tail end, like an amazing plan for that kind of local recruitment and seeing students all the way through to residency. But I also think that some of that is going to happen organically because your name's going to be out there. Students are going to say like, whoa, it happened to us. In our second class, somebody came up to us at Kansas City at the big national conference at the fair and said, oh, I'm from San Ysidro. I had no idea that there was a residency program here, that I could come back to train here. And anyway, make a long story short, that was Raul Trejo, and he trained with us. He's still one of our core faculty. In fact, really runs the quality improvement program, and I'm going to talk about here a little bit. So I think that students love the community health center environments and the opportunities to be involved with the community. And I think that you will see this kind of recruitment happening, especially if you, like Dr. Chen said, make it an intentional part of your program. Anyway, and so you will graduate residents that go on to be community health leaders. Okay, so now onto the ACGME and the look at what is the ACGME requirement. So, these common program requirements, I think that, did you present earlier on that?
Not yet, that is later today.
Later today, okay, I may stay, if I can stay for that. Anyway, so ACGME is, our directive, right, our requirements in many ways. And the common program requirements, the specific requirements to your specialty, family medicine, peds, internal medicine, OB, et cetera, are constantly being changed, actually, evolved, changed, becoming more detailed. And right now the common program requirements are in a lot of flux and a lot of change. I just had a little panic to our web ads. Some of you at the point where you're putting in your web ads this month. Yeah, so there was a whole new section on the common program requirements, and I just had to take a deep breath and realize we would get through it. But anyway, so the common program requirements for research is one area, and that every residency, no matter what specialty, needs to present just the basic principles of research, right? And how is it conducted? How is it evaluated? Why are we doing it? How do we apply the knowledge to patient care? And this is pretty general language. And why are we even doing it? Why, you're saying, we really want to have, good clinicians come out the other side of our training programs. And so why are we doing all of this extra scholarly activity, and where are we going to fit it into the program and all those kinds of things? So this is a lifelong learning process, right? So I would hate to be practicing what I learned in the mid-'80s in my residency program. Some things actually have come back to the future and are still very, very relevant, but there are things that are advancing all the time. And if we aren't, we really want our residents to leave with that, culture of curiosity, of lifelong learning, always wanting to be at the cutting edge and to know, what's best for their patients. And the goal is that this will also help with the triple aim. I guess I should also add maybe the quadruple aim now, but for better health and health care, and at a more affordable cost. So, and what residents learn, I think this theme has come through already today, what residents learn during their residency is what they're going to take with them in the future. So even if it's basic ability to read an article critically, to apply what they read, say, does this actually apply to my patient population? Does this number needed to treat, is that important? Am I going to really change my practice based on this new recommendation? So I think that even just these basic principles, having your residents leave with that, are going to make them more critical and better physicians as time goes on. All right, so a little more detail on these guidelines. So what is a scholarly activity? The guidelines say that this is an activity that contributes to the knowledge in your discipline. And so an activity that will contribute to knowledge, it needs to be shared with peers, so it needs to be disseminated. That means that, and you'll see there's different requirements for residents and for faculty. Is it subject to some peer review? And that can be just your immediate peer, or obviously for publication, something, a larger peer group. So there are different expectations, both for faculty and for residents. The faculty expectations are like a slight notch above the resident expectations, but the faculty have a little bit longer time to complete those. So for a faculty member, the recommendation are 2 scholarly activities over the course of 5 years. So every 5 years, each faculty member should have their name or be involved in a scholarly activity. And we'll talk about what those are. At first, it sounds kind of daunting. It doesn't mean you're writing 2 papers every 5 years, but you're involved in a scholarly endeavor. And somehow that is being launched on either a regional or a national level, some dissemination. Now, the resident requirements are a little bit different. Obviously, usually they're going to be with you for 3 years or 4 years, depending on the length of your program. And the requirement is 2 activities per resident over the course of their residency training. And those also need to be disseminated locally, statewide, regionally, or nationally. And that could sound a little daunting, but there are some great strategies for meeting that. Now, of those 2 requirements, you'll see we're going to get a little more into the details of the resident participation. That's going to be my main focus. So 2 scholarly activities. This is an increase in the time that I've been at this. 1 must be a quality improvement activity. Okay, so that 1 must be quality improvement. 2 could be quality improvement, but 1 must be quality improvement. And so the program, what our responsibilities are as program personnel and infrastructure is that we will provide resources to facilitate this resident involvement, and we will track that scholarly activity so that we, at the end of residency, we can show that the residents have completed this. Probably many of you are starting, either have chosen or will be choosing a residency management suite, something like New Innovations. That's one that we use. There's MedHub, there's My Evaluations, there's so many now, but all of them are going to have some features where you can track these activities, or you can use a old-fashioned Excel spreadsheet. Every year in your web ads section, as part of the new accreditation system, you will be commenting on the resident scholarly activity. Basically, you're attesting to what they've done. All right. So I've scattered a fair amount of photos just to kind of keep things a little lively here before lunch. Being in community health centers, we right from the beginning and have taken the approach that for the most part, these activities should reflect our community. What we care about is how are we going to provide better care for our community, for our patients. So a lot of our work in the scholarly area has linked to either community initiatives or health center initiatives. And so I'll go into a little bit more detail. One that we've been involved with 5210, which is a childhood obesity prevention program, nutrition and physical activity. This has been a community-wide project, part of a Promise Neighborhoods project in the south of the state, and this has been actually a very longitudinal scholarly activity, different residents jumping into different parts of that, but this particular section had to do with working in an elementary school with 4th and 5th graders, and actually there was a baseline assessment and then interventions, mostly health promotion interventions, and then reassessment of knowledge, and you're putting that together. So you can see that things that you would want to be doing and getting out to the community and making a difference are things that would lend themselves to a scholarly endeavor. But to go into, when the ACGME looks at this, they're saying, okay, they are using a rubric called Boyer's, which probably many of you already may have heard of and may be very familiar with, looking at the principle of scholarship in 4 different areas. So to review those are discovery, building new knowledge with original research, kind of the traditional thing that you might think of immediately with scholarly activity. Integration, how do you synthesize this knowledge and make it pertinent to others? How can you make it useful to others? And we'll go into each detail. Application, how do you take this knowledge and improve your healthcare, your care of your patients? And then teaching, so how do you look at developing a new curricular area, either for your residents, for medical students, for faculty, for the public? So we'll go into each of these different areas. Okay, so, and give some examples. There actually is a very nice, I think I added it to Dropbox, and we could have that as a separate handout. There's a very nice ACGME summary, 4 pages, that I've summarized here, which is all the different categories and some examples for a resident and for a faculty and how these different areas could be applied. So I think that could be helpful. So this would be, maybe an EPI project. I know that's had residents look at blood pressure control, STI trends, things like that. With working with public health, you could have a poster presentation at a residency fair. Poster presentations, I feel like for us, we need to, step a little bit beyond that, but I'll tell you they are a good first step, and it's also an area where a resident and faculty can work together, and this is helping both groups. And then, of course, an original research paper or abstract. And so, population, this was a immunization project for adult immunization rates. Peds immunization rates are often outstanding in health centers. This was some years back, our adult immunization rates were actually not so good, and so we developed a project around improving those rates, and we're able to show a significant improvement in some of our team-based and PCMH principles. Integration, so how do you synthesize current knowledge and make it useful to others? So to your patients, to policymakers or educators. So here, this is actually something that's done quite regularly, and a good place, I think, to focus in primary care, where you could be having an interesting patient, and then you do a case study and a literature review, and either present that at a case conference. You may take that to do a case poster, case study poster. There's public health issues, whether it's violence, whether it is the obesity issues, just whatever the public health issues are in your community. You might have resident and faculty writing an op-ed piece, maybe patient education, etc. A clinical review of a topic, testifying at, we've actually been involved in quite a bit of having residents and faculty testifying at school districts regarding chocolate milk in the schools, which was actually very controversial, and because there's a milk lobby too, so it's actually very interesting. You find yourself in some interesting situations related to this. But we've testified for open space, for park development. We had a resident who did a longitudinal project related to safety, bike safety and bike lanes in our community, which is not something that really was there, but she got involved with a group and ended up advocating at a city council meeting, and there's not, as part of that big project, there are steps moving forward in this very arena. Then in the area of application, this is where you're applying to your patient population. I think this is where quality improvement projects come about, right? So you have clinical goals, either blood pressure goals, diabetes, health maintenance goals, screening goals, etc. And then you can look at what is your baseline, how are we doing in our clinic setting, and then working together for an intervention, implementation, and reevaluation, and see if you can make changes. And I think this is, again, a core area for both community health center settings as well as primary care residencies. I can give you a few examples after. This was another immunization project, actually in seniors for pneumococcal vaccine administration. And then teaching. So a lot of you are starting out, right, developing your programs. I mean, you just got accredited, but that still means that there's a lot of curriculum development that needs to be done. So actually a really outstanding area for scholarly work, especially at the beginning, is looking at your curriculum development, and designing, implementing, and evaluating curriculum is fantastic scholarly work, and that gets full credit for the ACGME. And I think the piece, and I know that it's hard sometimes, it's the evaluation piece that doesn't kind of get done to close the full loop. So, evaluating the curriculum is I think a key piece. So how do you start? I think this can be very challenging. Like, where do you start? You've got so many other things on your plate, and how do you start? So there was actually a nice, just almost like an editorial, a small review in Annals of Family Medicine from just a couple of years ago that talked about, well, how do you develop this scholarly culture, right, of curiosity, of inquiry? And I think it does take building into your program curriculum dedicated time for research, both for the residents and then time for the faculty. So when you're putting your faculty time together, they're obviously going to be doing clinical time, they're going to do precepting, you know, maybe some are going to be doing inpatient precepting, but some piece of their time does need to be protected for scholarly activity that can probably overlap with curriculum development and other administrative tasks, but it isn't probably realistic to have that all be extra, because that is, you know, a potential for burnout. So I think sometimes these pieces are a little bit harder to to maybe talk to the administration about, like the needs, the time needs. But I think that's where your ACGME requirements can actually be your friend. I'm not always someone who likes to check, you know, I'm like, oh my gosh, I'm under so many requirements, but I have found many times that requirements, you know, you can speak to your administration, I think, with requirements and saying this is something that must be done, and somehow we have to figure out a way to carve that out or to work together. If you build something into your institution or to maybe your community, maybe there's a couple programs, so there's a med school in your program, then thinking about either a research day, a scholarly day, or even just within your program, so that there's a time where the residents are going to present, the faculty are going to present what's going on. And then there are certain things that can be developed into your curriculum. So when we talked about a case review and presentation is a scholarly activity. So we build that in for every third-year resident. Every third-year resident has a clinical case review that they present. The critical evaluation of articles and learning about research. You'll develop undoubtedly an evidence-based medicine series or a journal club series where the residents and faculty together are analyzing an article pertinent to your patient care needs. Being involved in M&M presentations as well. These are all ways to critically look at your patient care, and as long as it's formally done and it's presented, even locally for residents, those are considered scholarly activities. Okay, so where to start? So those are some building that, in general building the curriculum, and I think actually in the community health centers, and as we have grown closer and closer to San Ysidro Health and their quality improvement department and their research department, there's just such a natural collaboration there. So this is hot off the press from 2019 from San Ysidro Health, and probably most of your health centers are going to have something like this where, you know, what are your goals? What are your health centers' goals for quality improvement in the coming year? And then residents in their teams can be working on the similar projects. I'm just going to, I don't know if this is helpful or not helpful, but I'm going to just list a few things that have come up for us over the years, and also to make a plug for not only aligning with health center initiatives, but also looking, you know, I'm in family medicine, but whether you're in peds or you're in medicine, through your societies, there are often opportunities. And I always encourage my residents to apply because you may get the opportunity. So we've had some funding from the AFP Foundation. They often have research funding. For a long time, they have these immunization grants. We had 2 or 3 of those in a row where it really helped us focus. It's like very tiny amounts of money. It's not about the money. I think it's more the structure. And then it also gives you a forum for presentation later. It really helps focus the work. The AFP Foundation also had more general research competitions that you can apply for with a project, with a community-based project. These residents from a few years back did a pedometer project with an elementary school with 5th graders, and they actually won a national award with that from just, you know, working through the steps in the foundation, and it was really excellent. Just recently, the ACGME had and they're going to be continuing this program called Back to Bedside, which is trying to bring the joy back into practice by getting us away from the computer and back to the patient's bedside is in kind of a simple way, but it's led in our program to analyzing improved bedside rounding in the hospital, in the clinic setting. Again, it's looking at ways to improve efficiency, to bring sort of basically the joy back in practice because you're having more time with your patients and less with the computer. Just lots of, there are just a myriad of opportunities out there. Statewide too, there was a Future Faces of Family Medicine project that had to do with more structured mentoring into high schools, and that's been a beautiful project too. So I think, again, in our settings, looking at public health and community health is really important and lends itself naturally to what we do. Make sure. And I think it was mentioned earlier, Dr. Chen, how important the community medicine curriculum is. You all have the opportunity to build a very rich community medicine curriculum. We keep all of our first-year residents together in the first month of residency and around community medicine. So it gives us an opportunity to introduce the whole concept of community-oriented primary care projects, which is our second scholarly activity after our quality improvement projects. We encourage residents during that time to attend the national conference. We have a San Diego Academy conference during that time where resident posters are shown. So we kind of introduce the whole concept in that first month of community-oriented primary care. And many of you may be familiar with this as well, but it is a structure, a very nice structure for scholarly activity that involves identifying your community, and that community doesn't have to be, it can be a zip code, it can be a census tract, it can be a school, it can be the patients from your clinic, their zip codes, et cetera. It depends on how you want to define your community. And then it's working with community members and leaders to identify an issue in that community, working together on an intervention and evaluation. And so that is a scholarly approach. You may also hear it as community-based participatory research. And it's a similar model where the community is involved all the time. You're constantly reevaluating. And one of our early steps was working with an alternative high school that had a student board that and very high youth risk behavior surveying data, like a lot of risks in this community. And we had two residents that started working with this school, and they were going to be putting videos, educational videos together. And our initial thought was, I think the residents' initial thought was, oh my gosh, we've got teen pregnancy, there's got alcohol use, there's drug use, this is like so much going on. But when we listened to the students, what they wanted that first video to be about was how to get into college. Like, how do you take the next step? And that was such, I think, a really good message for us, is that the value of this community-based involvement is that it's not coming into a community and saying, I think what you need to work on is this. It's listening and then working together to make a difference. And then later, the two other topics that I remember was, after that kind of a positive look at life was, what you do if someone comes to you and your friend is suicidal, and how would you get them to the help that they need. And I think the other, this was some years back, the third one that they did was on rohypnol, the date rape drug, and like how to, protect yourself as a young person. So I think a lot of trust was developed by listening to the community first, and that's just a small example of that idea. Again, this is over many years, just a vast number of topics that have come from a combination of resident interest and community need and community interest. Right now, we have a pretty exciting project going on related to lactation support, and it's a hospital measure, but it's also a health center measure, around lactation and better support in the community. And one of our faculty is a PI on a CDC REACH grant, which is racial and ethnic approaches to community health through the CDC. Again, grant opportunities and scholarly opportunities that really lend themselves to the health center settings. Buzz through. This is something that may be a little bit more, detailed and longitudinal. This was part of that 5210 approach to childhood obesity, where this is a mapping of elementary schools in Chula Vista. Red is high BMIs, blue is low. Chula Vista is divided right down by the 805 freeway. The west side is a much more challenged community, socioeconomically, more transient, more fast food. Just the east side is more affluent, more parkland, et cetera. And this was kind of a shocking map. Well, I don't have the follow-up map, but over the course of, this is now probably 5 years, this map has changed. And our group has been a small part of a much bigger project, but really has been gratifying to see that working together with the community can really make a difference. So now there aren't any more red schools. There are no more red, although there's still orange and yellow, but there's no more red. And that's a step in a kind of short period of time. So this is work that has been written up and has been presented nationally. Because we're on the border, I just wanted to mention a couple of, we have some binational projects and partnerships. This is a collaborative project in Tijuana looking at tattoo removal and effect on depression and mental health. And not everyone's going to be right on the border, of course, but each of you in your community are going to have special populations and pockets and populations that really are disenfranchised or in need. And I think that if you identify and work together, it can be just so meaningful. Similarly, a little bit further south in San Quintin, over the course of 5 years, been working with a community center there and doing some health promotion activities. And the work of the residents was actually presented at the AFP Global Health Workshop. Okay, last couple of minutes is just, so we talked about dissemination, and it seems like, oh my gosh, that's hard too, poster and getting to a conference or writing and all of this. So one thing is to start local, right? Local and regional. So we have at Scripps Mercy San Diego, which is our sister hospital, has an internal medicine residency, and they have a Geller week, which is basically time for residents to present their scholarly activity, and our residents have been incorporated into that. So you can do that locally with your health center, as I say, with your community. The CAFP, the California Academy of Family Physicians, has a yearly clinical forum, and over the course of the last, I think, 4 years, there's been a resident poster contest, either in case presentations or original research, which can be quality improvement research. And then even locally, our San Diego Academy of Family Physicians. So you might find that in your community, whether it's your family medicine or PEDS society, would welcome something like this as part of their own yearly conference. And the other thing that I have unfortunately missed a lot of abstract deadlines too. STFM is coming up in September, mid-September, Society of Teachers of Family Medicine. So even, to start out, some of you that have developed your program or have developed a curriculum for your program could present a poster on that. I mean, these are all very viable options, even before you get residents. And so I say all of these professional associations, their educational meetings, they are really ripe for resident and faculty presentations or posters. Yeah. Oh,
So,
yeah. Mm-hmm.
Does your program provide any funding to the residents, either in incentives or in reimbursement for presentations?
We do. We, if for meetings where the resident is going to present, we do provide the funding for that. Nope. Yeah,
Okay.
For them, for the travel and participation.
And is there any sort of, for lack of a better word, incentive bonus if you?
We don't have no financial bonuses.
Okay.
No, we don't for anything. We don't have any financial bonuses. I know that just hasn't been part of our.
You've achieved a ton without it. I mean, I'm not saying you need to.
Yeah,
I'm more asking the question for folks in this room, because I know some of you have tried to wrap your head around some of this stuff, or will be as you're looking at residency programs. So just wanted to highlight that a little bit.
Yes, no, so we do pay, we have a very small educational fund for every resident. I would like to work on raising that. It's not very much, several $100s a year. So that's not so much. But again, if someone is going to present, so like these are presentations. Oh, a lot of people would like to go to the national conference. So I always say, if you get accepted in national conference, you get to go. If you get a poster accepted, if you are able to go. So residents like that. The AFP, how many are involved with family medicine residency development? So that's pretty common then, good. So the AFP National Conference is, first of all, it's fantastic. Were you all there in Kansas City? Some of you there this year? And but residents can apply. They've actually expanded the categories now. Clinical inquiry, which is kind of your case conference, your case presentation, original research, and educational programs. So our residents that presented this year presented on the back to bedside rounding and that project, or a community project. So look at that. That's everybody could present there. There's also, I want to make a plug for Family Medicine Leads, which is not only offers scholarships to your residents to attend the conference, but there's also a year-long fellowship in the Emerging Leaders Institute. We've had 2 residents go through that, and one, who's now one of our faculty, started with adding a public health module to our mentoring curriculum that we do in 3 different high schools, and then built on that as a faculty member, and now this summer had worked with UCSD with their HCOP, Health Careers Opportunity Grant, and put together this 6-week curriculum and summer camp for selected high school students from our area. And so now that's going to be presented, she's going to apply to present that at STFM. So you kind of see how it started out as a resident project with some support, got more complex and more detailed as a faculty, and now it gives her that opportunity. So this is a little bit. Okay, I think this is my very last slide. This is just to remind you where we are. We're just a few miles from the border. This is actually, just in this time. This is a kind of a dynamic and somewhat emotional place to be, but this is actually a picture taken by a colleague about 20 years ago, and that was when families could actually picnic together through the border, and that's really not possible now, but it just reminds us that our border is very dynamic, and I certainly love being there and being part of that community. So I'm sure each of you will be able to build those linkages in your community that really make this even more rewarding. So anyway, thank you. Any questions on this topic, or thinking about where it might fit into your curriculum? Yeah.
So
you're a PhD.
Comment.
Yeah.
The comment is the program's absolutely amazing. So I worked at BCI. And the
yes.
Still the best of the best.
Oh, yes.
Go to Chula.
Oh.
So I really recommend it.
No, thank you.
You're right. Students they will talk to each other, and the recruitment will happen by itself.
Yeah.
My question
Thank you.
is, so I was involved with the scholarly activities for our residents of family medicine. The struggle that I had the most was, usually what would happen is a week before they're graduating, or 2 weeks or 3 weeks to get a survey out. That's the project. Boom. And so I saw that you had community medicine areas where you didn't have opportunities to do it. Is there anything that's kind of scheduled in that, with all the rotations they do, whether it's an elective, there's something that you have in terms of when they can do it?
Yes, we've struggled with that too. I just just to be fully candid. But I did skip over this. In the quality improvement area, we have developed more time and more structure. So we have a patient-centered, I should have said this actually, we have a patient-centered medical home rotation, which is also 3 months. I think earlier somebody showed, I think Dr. Chan showed from one of the programs where there was a 3-month leadership or chief rotation. And ours has actually evolved. We used to call it the clinic resident month. It's evolved over time, I think, to be a little more robust. So it's a patient-centered medical home rotation, 1 month in the second year and 2 months in the third year. We have, so that is, during that month, there is carved out time, it's Thursday mornings primarily, for quality improvement. And we also have pod model, and teams. And so it's approximately quarterly. I think the project changes. Sometimes some go a little bit longer and some are shorter. So the teams will have the pods will have a project selected. Right now, we're just embarking on improving the use of advanced directives, for instance. So we're just barely scratching the surface there. So on that Thursday morning, Raul Trejo, as the faculty advisor, is there. There's always 2 residents on patient-centered medical home at one time. So they're working together on that QI activity that morning. And then we've also, this is not working 100%, but we are trying, where we're taking residents from those teams or those pods that are on outpatient rotations. Let's say they're on their GERI rotation or med subspecialties or whatever. They also are there for at least an hour in the morning. I think it's 8 to 9 is what we aim for, to be part of the core discussion. And then we have some of this, to be honest, I got from another presentation in a program director's workshop a few years ago, where then they've also created then a living document. So the work of that quality improvement project keeps moving. And then at some point at the end of their block, the patient-centered medical home residents do a presentation of where they are in the project. So some residents will be at any one time be more involved in the development, those steps, and others will be more involved in the evaluation, but somehow it turns out to be a whole team project. That's some. Then I've had other residents that have, for instance, done HIV screening in teens, improving HIV screening in teens and adolescents. And it was a pod project, but one of the residents really took it on as the leader and then ended up having that be their main scholarly project. So we build it in that way. But it is a challenge. We have some rotations where we block out a half day, periodically for, we call it COPC time, but it's not as consistent. It's been a challenge. So, but we've tried in that area. Anything else? Questions? Thank you.
Thank you.